Dr. Dharmanand, who will be speaking on quality of life measures and their relevance and use in routine practice. Dr. Dharmanand, I think most of you are familiar, is a consultant, leading consultant rheumatologist in Bangalore. He graduated from Mysore Medical College and did his DM program from Madras Medical College. And he's been working as a consultant rheumatologist at ChanRe and more recently until last month at Manipal, and has now moved over to a new hospital called Sakra on Sarjapur Road. Dr. Dharmanand is the current president of the Karnataka chapter of Indian Rheumatology Association and is secretary-elect of the Indian Rheumatology Association at the national level. He has been a principal investigator in many clinical trials, and I think most of you have heard him many times. Most of his talks are very relevant and practical to your daily practice. I hand over the mic to Dr. Dharmanand.
Good morning, everybody. Thank you, Chairman, for the introduction. It's nice to be back here. Last year, I missed the meeting due to my illness. And you must have observed, the non-rheumatologist here must be wondering, more you know about rheumatoid arthritis seems to be more and more complex. I would have been happier with my knowledge, MBBS knowledge of rheumatoid arthritis. More we read, more we try to do things. Rheumatoid arthritis is becoming more and more complex. And rheumatoid arthritis, apart from affecting the joints and causing pain, which makes the patient to come to the doctor, it also affects the patients in a psychological way. Some people say in a spiritual way. So we can always assess the joints by counting the number of joints, asking the patient how many joints are hurting, and you examining physically and looking at your ESR. Sometimes you miss, if you don't ask, how this disease is affecting their personal life, professional life, sexual life, and all other spiritual life. So there are other measures which have been developed to address this question. Next 10 minutes or so, I will brief you what are the measures available in the practice for us to use, and what are the usefulness of doing these assessments, and also what are the pitfalls. What are the quality of life measures available to us in the literature? One of the earliest ones which became very regular in practice is arthritis impact measurement scale. There are various versions of it. Depending upon the number of questions you have to ask, either it is 19 score, 9 score, 14 score. So people have been trying to make it more practical. It is a patented tool, so not easily available for everybody to use. HAQ, Health Assessment Questionnaire, is one of the earliest questionnaires, patient assessment questionnaire, which came out somewhere in late 80s, published in 81. And subsequently, it has been modified into modified HAQ and multi-dimensional HAQ by Dr. Theodore Pincus and his team. From this, a new tool called Rapid3, which is a patient-driven assessment tool. So these are all the HAQ and its variants, and Rapid3 are used now in many clinics in various parts of the world. SF36 is one of the classical quality of life assessments tool, but it is a very long one, cumbersome to use, but it is very useful in clinical trials. It assesses almost 36 aspects of quality of life. It's a busy slide, but it assesses various parts of physical functioning, and also pain, our psychological reaction to it, social functioning, etc. So it is very, very exhaustive, but time consuming, almost 4 to 5 pages. It takes about 30 minutes for a patient to fill this up. Many patients require help to fill this up. And it is generic. It can be used in any disease. It is not arthritis specific. It can be used in any chronic disease. So it is used extensively in trials. Those who have done trials, this is one of the tools which is used extensively in almost all the rheumatoid trials, but it is not useful in the clinical practice. HAQ is health assessment questionnaire. This has only a couple of pages, about 13-14 questions, which can be done on a paper, or now electronic online versions are available. This is one snapshot of online version. You just click, depending upon, the question is whether you can dress yourself up and tying shoelaces, etc., shampoo your hair. So without difficulty, with some difficulty, with much difficulty, unable to do. So moment you click, is registered, and then move on, and after all the questions, you get a composite score. Modified hack was shown by Dr. Reddy. This is probably the most simple clinical tool which we can use. It has only about 8 questions. And this is how it is questioned. This is an example a patient has answered. For each question, like get in and get out of bed, there was no difficulty, so the patient has scored 0. Lift a full cup of glass to your mouth, it was difficult. Patient probably had difficulty in his hand grip, so he had scored 2. So the total score was 7, and divided by 8, you get the modified hack score. It's very easy, easiest tool to use. Probably all of us can. This is one tool all of us can use. Whether you are a physician or a clinician, it is easy to give this card to the patient. Patient can tick, and you can quickly calculate it. You can ask your nurse to calculate 7 by 8. I can't calculate in my mind, so you can ask somebody to calculate it for you with a calculator. From this, Dr. Theodore Pincus and his team has evolved what is called as multi-dimensional health assessment questionnaire. This looks very complex here. It's 2-page. It's only 2 pages, but a lot of questions. This is fully filled up by the patient. It is given in some clinics in the United States to all the patients who walk into the clinic. So the patients fill this up. The first 8 questions are useful. It assesses the function. The second the second lot of these 3 questions assess the psychological impact of the patient to the illness, and this is the patient assessed joint counts. You ask the patient which are the joints are painful, so they tick. Depending upon they tick, you can have a count. And this entire system review. So if the patient has got any other illness during the period before you were from the last visit to the current visit, the patient ticks, and also the patient assesses your fatigue and any other aspects, any other concurrent events, surgeries, etc. This is a kind of a complete picture history we would like to have from the patient, but we don't have the time to get it. So give it to the patient, they tick it, and when they come to the clinic, they show the paper. Depending upon where they have ticked, you know where to focus. This is an extremely useful tool, but looks very cumbersome. See, Dr. Theodore Pincus has assessed. This is his MD hack. It takes about 10 to 15 minutes for the patient to do it in the waiting room. It has assessed so many factors. For us, once a patient comes to us, to calculate rapid 3, it takes only 7 seconds. So the patient does all the job. When the patient comes to us with this sheet, we can calculate their rapid 3, which is a useful assessment tool to say whether they are better from the previous visit to the current visit, and they also assess their overall disease activity. So it takes relatively shorter period. This is the rapid score sheet. This has got the number of questions where the patient asks, depending upon the severity of the disease, whether they can, without difficulty, with some difficulty, unable to do. So all the first 8 questions are scored, and it is given a weightage. And this is the visual analog score for pain and global assessment. With this, a rapid 3 score can be calculated in about 7 seconds. This is an example of the scoring system. So this is how the patient has scored. This is the joint score. This is the patient visual analog, and this is a patient pain analog, and the visual global, how the patient has felt about his disease globally. So it's given a scale between 0 to 10. So depending upon what the patient has scored, you get a rapid score. This is a very useful tool. There is also a criteria. Patient scores very low, within 3 is in remission, between 3 to 6 high disease activity, more than 13, 14 is a high disease activity. It's easy to do it on the clinic. It doesn't require any effort from the clinician. And Professor Theodore Pincus from NYU hospital in US has gone on to the extent that this can be like a vital sign in a patient with arthritis. Like if you have a quick rapid score, which is patient driven, if it assesses the pain and function, it gives us an idea how the patient is functionally. And does it matter? The functional decline, the hack determines the 5-year mortality much better than other aspects. So if the patient has got very high hack score, they are more likely to die in the next 5 years. And the patient who is functionally less active are more likely to die. It is almost comparable to the smoker and non-smokers. So a hack score gives us the information about the patient's future possibility of decline in function, and also gives us the detail about whether this patient is likely to die in the next few years. So one more incentive for us to look at this, so that we can do everything to improve the functional status, so that their long-term decline is prevented. Again, this is one of the slides which shows that one of the best predictors of mortality is baseline hack score. Somebody who has got a persistently high score in the functional hack, that means they have poor function. That is the one which predicts much better than your ESRs, CRPs, your erosion scores, etc. So assessing the patient's function gives us a lot of information about the long-term prognosis of these patients. So this is one busy slide from Dr. Pincus. So hack or MD hack, and not a joint count, lab test or X-ray, is the best predictor in RA of functional status. These are all the references. Work disability, cost. These patients are going to incur higher health cost. It also predicts the patient's future joint replacement surgeries and also predicts death. So, ladies and gentlemen, why should we use quality of life measurements in the clinic? So, as I have reiterated in the last slide, it is a better predictor of the future of the patient. And also the rapid 3, which is calculated through these measures, distinguishes active from control treatment in clinical trials as effectively as DAS28 and the clinical disease activity index, which require a physician to measure the joint counts. So even if you leave it to the patient, even if you don't touch the patient, if the patient comes to you with a functional assessment tool and their own assessment of their pain and their global function, it gives as much information about the disease activity, and also it measures the change from the visit 1 to visit 2. So it gives useful information. It doesn't negate the need for joint examination. Unless you feel the joint, the patients are not going to be happy, and we are not going to be happy as a doctors. So we need to examine the patient to give the clinician effect to the patient. Whatever benefit the patient gets from your clinical visit, is 50% is from your medicines, 50% is from you as a doctor, the impression they get, the aura surrounding the hospital, and the way you talk to the patient, the way you touch the patient. So we need to touch the patient. This rapid 3 and hack doesn't negate us from feeling the patient, touching the patient, but it gives us much information. So it is not a bad idea to collect this information in the clinical set. And here patient does all the work, so we need not do. And we can, once the patient comes to us with this. And one more reason, if we assume that we are doing the functional assessment, patient comes to us with one of the hack scores. When you eyeball you know what are the difficulties. Patient has difficulty predominantly in using the hand. So we can probably focus our clinical examination during that visit to that particular joint. Let us probably closely examine this joint. 1 or 2 joints are swollen. If they are not responding, probably we can offer them to inject the joint so that the functional grip improves. Or if they have difficulty in predominantly moving into the car, so we can look at the lower limb function. So it gives us an opportunity to focus on a particular symptom which bothers the patient. Otherwise, we'll ask, how are you? Patient has to say, I'm okay, sir, better, but still I have a little bit of pain. And by the time we were halfway through our prescription and send them off. So we don't have much time. So this gives us an opportunity to help us to focus on the areas which matters to the patient. And also it provides, I've already discussed this, it provides a platform to discuss some of the issues which would not come into the attention usually. So if the patient has got a lot of giddiness and other things in the MD hack, if he has circled that, at least we can think about whether he is getting any of the drugs which we are using could cause a postural hypertension. We can assess these issues. Otherwise, we will never discuss these issues without these columns. And more importantly, most of us, our patients complain that we have to wait in your clinic for half an hour, 1 hour, 2 hours. So if you give this form, and it takes average 15 minutes for an educated person, probably an average, our patients, it will take maybe about 30 minutes. So it keeps our patient engaged in the waiting room. Probably it would save our nurses and secretaries a lot of hassles. What are the difficulties? Why, in spite of the knowledge that it is useful, many of us, including us, we're not trying to follow this on a very routine basis? Why? Probably giving these measures, doing a patient assessment is not considered sexy. Vis-a-vis ordering fancy lab tests, doing a ESR, CCP, doing some HbA1c, looks very attractive. So we as physicians are inclining more and more towards doing something which is more easy for us, writing a prescription, getting a drug, ordering a test, rather than assessing the function. So it is not considered very, very attractive for us. And most of us perceive that it is very time consuming. Actually, the most of the time is taken outside your clinic room. So patient does it in the office waiting room. When he comes to you, you are just going to flip through it, which takes few seconds only. So it is not really time consuming, but there is a perception that moment you see the dash sheet with maybe 200 lines in 2 pages, we feel that it is going to take a lot of time. So we mentally block and we don't do it. And education level of the patient also influences the uptake by patients. Because mostly English versions are available, we don't have reliable Kannada or regional language translations. So many patients who can't use English efficiently may not be able to use this tool. And also our patients culturally are not used to all this. Extremely difficult to elicit answer for a simple question. On a scale of 0 to 10, how much pain you have now? If we ask this question, 50% of my patients have difficulty in answering, because probably culturally we are not tuned to give a mark, except for college students who give marks to beauty of a girl, or probably the current generation of TV watchers. They are used to the talk shows and music shows, dance show, people giving 9, score 9, 8. So they understand the concept, but many of them have a difficulty in understanding the concept. So I am better than last time. So no, we are not interested in whether you are better or not. I want you to tell how much pain you have. Assume that you don't have pain. If you don't have pain, you are going to give a score of 0. If you have very severe pain, like delivery pain or a fracture pain, you are going to give 10 out of 10. How much would you give? You only give, sir. So you only approximately put, sir. So it is, people have difficulty in getting the concept, though I am trying to be clear. So culturally there is a difficulty in eliciting this question, but the current generation, youngsters are quick, 8, 7, they will tell without any hesitance. But people of my age and above, who are touching 50 and above, find it extremely difficult to get this concept right. Probably we are not used to doing this from our childhood, but the current generation is very quick. The moment I say what is a how much difficulty, fatigue, they say, within second they say come out 6, 7. So probably it may be useful in our our younger doctors should be able to use it much better because they are going to deal with the younger generation of patients. And many of our patients also, whichever clinic they have gone to, nobody bothered about this questionnaires. What this fellow doctor, let him come, examine me, give a prescription. Why is he asking so many questions? So this is also a factor we have to overcome. But, so they are also not very comfortable with this extra responsibility thrust on them. But I feel that if we consistently start using them, our patients will get used to it. Chandrasekhar's patients are getting used to it now. So many of our patients are getting used to it. So if we want Chandrasekhar, they have to go through this. So people get used to it, and I think we will get more useful information about the patient, and ultimately these tools should improve the patient care. I think I've done. Thank you very much for the patient here.
Thanks, Dr. Dharmanand. Are there any questions for Dr. Dharmanand from the floor?
Thank you for your presentation, sir. I just wondered how these tools, measurement tools for quality of life measurements, developed for some other population, can it be used for Indian context, Indian population, whether the obtained data or the measured data is sensitive for the Indian population also?
Very good question. For many of the tools, we don't have an Indian version, but we have an Indian hack version, which is validated. Dr. Arvind Chopra and his team, and there is a team from Arun Chogle from Bombay. They have two versions, Indian versions of hack, health assessment questionnaire, which has been validated by Indian studies. So, see, there are few cultural questions which doesn't match, but overall, if you look at each question is grouped under, say, grip strength, the 2-3 questions. Mobility, there are 2-3 questions. 1 or 2 questions are still relevant to our patients. So overall, if they score, even if they cannot understand one particular question and able to understand the second question, we'll get the useful information. So it is still useful, but there are no like a large scale studies to say that Indian patients, it has been validated, but hack has been validated.
Thanks, Dr. Dharmanand. I think I